Okay. Hello, everybody. I've been told that we are live, so we're all ready to go. For those of you that don't know me, I am Geoff Lawrence Smith. I am, I'm not sure, I might be Director of Neuromodulation, but I might also be just liaison psychiatrist at Royal London with a penchant for TMS. This afternoon, we are going to have a number of talks on the topic of ECT and neuromodulation. I think we've all had experience of and been exasperated by mental disorders that sort of seem to defy all our attempts to treat them and cause massive distress to those that have it. Treatment-resistant depression has various definitions. The most widely accepted being that which fails to respond to 2 or more treatments of an adequate dose and an adequate duration. What that really means is anybody's guess. Now, despite that, estimates of prevalence of major depressive disorder and treatment-resistant depression range internationally from 12% up to 50%, depending on the studies done. Now, this afternoon, so I suppose the question is, how do we support people in this situation who have not responded to standard therapy? One answer is neuromodulation, or as it is sometimes called, and I quite like this, interventional psychiatry. I like interventional psychiatry. I'm an interventional psychiatrist. Now this afternoon we've had 4 speakers to talk to you about various modes of interventional psychiatry. First, we have Dr. Daniel Allen, who's going to do, no, it's not keynote, is it? No, it's not keynote. So he's here to do a talk on ECT, relatively short talk to get us up to speed and remind us what we had to begin with. Then we have my colleague, Professor Alex O'Neill Kerr, who is an adult psychiatrist and he's a medical director of Transforming Mind Solutions, where he specializes in transcranial magnetic stimulation and direct current stimulation. He also does ketamine clinics and vagus nerve stimulation. He's going to talk to us about TMS. And then we're going to have a break. And then after the break, we have Rupert McShane, who is going to talk to us about ketamine and the developments in using ketamine, before which, still again, home grade, we have our Sylvia Mergia is going to talk to us about how we integrate psychological treatments and support to the various neuromodulating techniques that we use. Okay, so get your pens out, think about what questions to ask, and I will start with my colleague Daniel Allen. Thank you very much.
Thank you, Geoff. You won't be clapping at the end. This is not moving on. Why are the slides not moving on? Good to know that everything's gone off without a hitch from the start. Ah, there we go. Lovely. So, good afternoon, everybody. Thank you all for coming. Before my distinguished co-presenters and honoured guests will stand up to tell you about the exciting new technologies that we now have available, I am here, first of all, for about 15 or 20 minutes of your time to tell you that, frankly, sometimes the old ways are the best. To take you through a very quick potted history and the current state of ECT treatment, the original, and in many respects, arguably still the best form of neuromodulation or interventional psychiatry that is available on the market today for your money. Just a little bit long-term history. The idea of inducing convulsions and giving electricity as treatment is it goes back quite a long way in history. The induction of seizures as a treatment recorded back in the 16th century. 1744 saw the first issue of the journal Electricity and Medicine, which I could not find online. It's the dawn of electricity's therapeutic use. 1756 documented treatment and cure of hysterical blindness using electricity. 1785, the London Medical and Surgical Journal reported the therapeutic use of seizure induction, and by 1801, Lind and Aldini were using galvanism to treat various disorders. By the mid-19th century, electrical treatment or electrotherapy or galvanism was considered integral to neurological practice, if not psychiatric. But our story with ECT starts in the 1930s with this chap, Ladislas Joseph Meduna. He was a Hungarian neuropathologist and neuropsychiatrist in Budapest, who, because of started to formulate this hypothesis that epilepsy and schizophrenia were on opposite ends of the same spectrum. There was various things that led him to this. Various histopathological changes seen in the brains involving glial cells of the brains of people with schizophrenia and epilepsy. And also the fact that there were some studies showing that people with schizophrenia or people with epilepsy seem to have uncommonly low rates of schizophrenia. And this led to him to begin experimenting with chemically inducing seizures. His thinking was, if we can induce epilepsy, if we can induce convulsions, we can treat schizophrenia. He gave his first treatment using intramuscular camphor in 1934, and then went on to treat over 100 patients in the next 2 years, around about which half of whom apparently recovered. He switched from camphor to metrazole. By 37, there was the first international meeting on this new convulsive therapy. It was reported in the American Psychiatric Journal. And by 1940, metrazole for chemical induction of seizures was widespread. Around the same time as this, Ugo Celletti, the hero that we all learned about when we were doing our membership exams, Italian psychiatrist, the reason I put there about the slaughterhouse is to remind me that, so the story goes, his idea to start using electricity to induce convulsions was occurred after he took a trip to his local butcher's to ask for a particular cut of meat from the animal, which hadn't been prepared. So he was directed by the butcher to the abattoir directly behind the butcher's shop. Where they were using electric shocks to stun the animals because it made it easy for them to then cut their throats and butcher them. And seeing these pigs being shocked in this manner, he saw that they were convulsing. And then he'd already witnessed chemical induction of convulsion therapy. So put 2 and 2 together and decided to start. He did a lot of animal experimentation, I think, in dogs, and was able to then demonstrate a reliable being able to induce a repeatable seizure. He gave his first treatment in April of 1938 to Enrico X. I don't think he was born. I think Enrico X was not born to Mr. and Mrs. X, presumably. He was a man who suffered from delusions, hallucinations, and confusion, and the first effective seizure at a higher dosage occurred on the 20th of April 38, and Enrico X went on to recover after a course of 12 treatments. Celletti and his assistant Bini were nominated for a Nobel Prize for their work in this regard. And then over the 40s and the 50s, widespread adoption of ECT versus metrazole. Metrazole had very serious drawbacks. There was after administration of the drug, you would have an unclear period of time before the seizure would be induced, whereas obviously ECT gives you your seizure immediately. ECT was also considered to be advantageous because of the effect on anterograde memory. It meant that patients very often didn't remember the fact that they'd gone through this quite unpleasant, unmodified ECT. Initially unmodified, no muscle relaxant or anesthetic, later becomes modified ECT with a general anesthesia. Curare is a muscle paralyzing agent that got replaced in 1951 with succinylcholine, the muscle blocker, which we still use. But then it declined in the 50s to the 70s, partly, I think, because of the discovery of the tricyclic antidepressants, but also quite significantly because of the counterculture movement, the anti-psychiatry movement, and very intense negative media portrayal. One Flew Over the Cuckoo's Nest, with a novel written in 62 originally, but really, and a successful Broadway play in 63, but then really break through in 75 with the film with Jack Nicholson in the lead. There have subsequently been analyses of the portrayal of ECT in film. And they generally conclude that whenever it's depicted, by and large, the depiction is completely unrelated to the real treatment protocols or regimes, and is very deliberately weighted as painting ECT as a stigmatizing ECT as a tool of mind control and repression of the individual. Yes. So where are we at the moment? So the current indications for ECT, based on the decades of evidence for it, are severe depression, especially life-threatening depression, intractable mania, catatonia, where it's a second-line treatment after high-dose benzodiazepines. There is no RCT data for this. It's a medical, catatonia tends to be a medical emergency, but it's generally acknowledged as having excellent efficacy. And also it's indicated for schizophrenia. It is widely used around the world in the treatment of schizophrenia, although in Western Europe and North America, it tends to be only for treatment-resistant illness and those unresponsive to antipsychotics. The evidence base is very significant. ECT Review Group did a very large meta-analysis 2003 and showed that ECT is better than sham ECT by a significant effect size of 0.91. And also ECT is better than pharmacotherapy. It's better than drugs. Significant number of trials with an effect size of 0.80. They also demonstrated that bilateral ECT, which we'll explain in a moment, is more effective than unilateral. The Royal College has an accreditation service, ECT accreditation service, ECTAS, which did release data in 2015 of 1,500 patients. 74% were either much improved or very much improved after ECT treatment for depressive illness. These are the kind of response rates that I suspect most drug company executives would sell their children's kidneys to be able to achieve. ECT also has a very prominent anti-suicidal effect. Now, it's been suggested that this might be possibly because people having ECT are seen regularly by a team of people, amongst other things, who are giving this lots of attention, and they're signed up to a course of treatment. And the other thing to note about ECT is that more severely ill patients respond best of all. If you're more sick, you get better, you tend to have a bigger response to it. The evidence base for psychosis, not as colossal, but still significant. Some meta-analysis evidence in 2019 for moderate efficacy for medium-term clinical response for people with treatment-resistant schizophrenia. And so the thinking now, ECT in schizophrenia or psychosis, is that it's as an additional augmenting agent for clozapine for those who've got an established treatment-resistant illness or intractably unwell despite that. It's also useful in pre- and postpartum psychosis for those who want to avoid medication. And it's been suggested as well that we should be using ECT more as a maintenance therapy for relapse prevention in schizophrenia. Worldwide, about 1.4 million people have treatment worldwide. In the West, it tends to be used primarily for depression. But in China and India and developing nations, it tends to be used primarily for schizophrenia because it's as cheap as chips. Unmodified ECT is still common in developing countries. We have in England about 0.43 patients per 100,000 people receive it. Current NICE guidance, reviewed in 2014, recommends ECT only to achieve rapid and short-term improvement of severe symptoms after an adequate trial of treatment options is proven ineffective, or when the condition is considered to be potentially life-threatening in individuals with severe depressive illness, catatonia, or a prolonged manic episode. The FDA guidance, I believe, is similar. FDA 2019, after a significant review of something like 3,600 submissions, concluded they dropped the rating of ECT machines from their class 3, which means all very dangerous, must barely be used at all, to class 2, not at all dangerous, really. Please be very, very careful with it. The general thing there is, despite my flippancy, is that it's, broadly speaking, safe. Treatment course is typically 12 treatments given twice weekly over 6 weeks. At our ECT service, we do these on a Tuesday and a Friday morning at the Royal London's theatres, on the main theatres on the 4th floor. The other thing to say about treatment is there is evidence for traditionally ECT is given a course by the end of which people have generally improved, and then we cease the treatment. But there is evidence for tapering off of ECT therapy rather than abruptly ceasing it, and also using more and more for maintenance therapy for intractable treatment-resistant illness. So just to take you through the standard procedure, team comprises 4 people usually: a psychiatrist, who's basically a glorified clamp stand. Once he's done the prescription, you just have to hold the rod still. 2 ECT nurses, the anaesthetist and an ODP. The patient is nil by mouth from the night before because they're having a general anaesthesia. They have their vital signs checked. They're instrumented with a standard 3-lead cardiac monitor, pulse oximetry, and an automatic blood pressure cuff. This is all standard anaesthetic kit for anybody having induction, with the addition that we put on EEG stickers, 3 across the forehead, one each on the mastoid processes, to give us left and right side baseline EEG, forgive me. Once that's all in place, you can see in the photograph there, the machine in the corner is our EEG machine, and that ribbon of paper sticking out the front is the EEG trace where we've checked the baseline prior, immediately before giving this patient their treatment. They're then cannulated, their oxygenation via face mask, and when we're all happy to go, the anaesthetist will give them, we use thiopental for induction, most places I think use propofol, and then they get their succinylmethonium muscle blocking agent, and we all stand and watch them do the succinylmethonium 2-step, wait for the fasciculations to fade away, and then the oxygen comes off and we step in and we give the treatment. They have a bite block that goes in as well. We'll set the prescription in advance. The machine dials from 1% up to 200%. We'll generally start you on 10% and then titrate according to your seizure duration. There's an impedance check when the electrodes are in place before we actually deliver the charge, just to make sure that there's not too much resistance. The EEG starts spitting out of the machine automatically as soon as the shock's delivered, and then we watch the patient and count the visual seizure duration. We aim for about a 25-second seizure. If it looks like they're running on past 100 seconds, which is very unusual, we will start to look anxiously at the anaesthetist, who will have some more propofol or more thiopental, just hopefully waiting in the syringe, just to give them an extra little slug, just to arrest and bring the seizure to an end. I've only seen that happen once in the 18 months that I've been doing it. And then as soon as the seizure's complete, the oxygen goes back on, and we just wait for the thiopental to wear off, and we wheel them round to recovery with all the other post-surgical patients where they wake up feeling groggy a little bit later on. Here is a typical EEG trace. The one on the left there is the baseline. We take about 5-6 seconds of baseline just to check that we've got a decent signal. And then the one on the right is that sort of curved line coming up, is where the machine is delivered, has sort of reset itself after the shock's been delivered. And then you can see the broad wave polyspike activity, which is characteristic of the seizure activity. And then it sort of attenuates. And then finally on this trace at about 25-26 seconds, we get suppression, where there is supposed to, I believe the hypothesis is the release of NMDA into circulation. That was what you told me a long time ago, Geoff. Was it right? Yeah. Or you just making that up to impress me, quite possibly. Sorry? GABA, obviously GABA. And that is just suppression. You do actually want to hopefully see a clear suppression, because that's where the magic happens. Possibly, nobody knows. Electrode placement is either bilateral. That was the traditional one. It's the one that we still tend to do because we're old-fashioned. The evidence is it tends to have a faster onset of action over the course of the treatment. It's considered by the review in 2003 to be moderately more effective than unilateral treatment, and you tend to need lower dosages, only 1.5 times the seizure threshold. Unilateral was introduced in 1954 in an attempt to reduce cognitive effects from ECT. It spares the dominant hemisphere, but you tend to need higher dosages, up to 6 times the seizure threshold, to get the same effect. Side effects: about a quarter of people get headaches. Give them some standard over-the-counter analgesia, tends to take care of that. About 15% might feel nauseous. We get that occasionally. So we often, if we know it's going to happen, we will ask the anaesthetist to give them a slug of an antiemetic while they're still under the anesthesia, and about 10% might report muscle pain. Very, very important point here, because we are all infected with the notion that this is an exceptionally dangerous, barbaric treatment, and it absolutely is not. ECT is extraordinarily safe. It's no more dangerous than the anesthetic that you have to have in order to have the ECT. 2.1 deaths per 100,000 treatments, according to a pooled analysis from 2017. And also there is evidence that it reduces all-cause mortality when it's used. Despite what legions of people will tell you on Twitter and various other cesspools on the internet, there is absolutely no evidence, and never has been anywhere, of any macroscopic or cellular brain damage ever. They're quite clear on this. They've been quite clear. The World Health Organization has been all over it. There is also separate studies show no evidence of increased risk of dementia or stroke in people that receive ECT. It is also safe in all trimesters of pregnancy and is arguably advantageous for many people because it can avoid the need for taking drugs during pregnancy. Drawbacks, cognitive effects. These are reduced using the current brief pulse treatment versus the original sinusoidal treatment. This was the shape of the wave that was used to, and unilateral treatment is supposed to reduce these. Standardized measurements given before and after treatment have shown that there are can be effects in short-term memory and executive function, but there are huge inter-individual differences going on here. And what tends to happen is that at the group level, these will resolve within weeks, and at that point, most scores are improved compared to pre-treatment. The other thing to bear in mind here when weighing the cognitive effects thing is we're only using this treatment for people who are about to die because from their depression or who are intractably unwell from a chronic psychotic or manic state. The amnesia is a definite thing. Anterograde amnesia is quite common, people limited, but it tends to be limited to the time of the treatment or the period immediately afterwards. Very often when we ask people who've had ECT in the past, do you remember it? They go, no, not really, but I do know I got better, and they ask for it to have it again. It usually improves. Some have reported persistent problems. Again, it's very hard to quantify. Retrograde memory losses, there are a lot of very vocal people talking about loss of autobiographical memory. Again, it's very, very hard to quantify because very often the people coming for ECT have got extremely severe depression, which itself has an effect on overgeneralization in autobiographical memory. And it's hard to make the objective measures of cognition correlate in any way with the patient's subjective reports. This is not to dismiss it, you understand. It's a thing, but it's very, very hard to accurately quantify. If anybody knows how ECT works, I'd be very grateful if you could put your hand up and let the rest of the room know now, because nobody has a bloody clue. There have been constant work around this. There are lots of hypotheses. I looked this up. These are the current ones from the best review I could find. I was told as a medical student that it was all about causing all the neurons to depolarize at once, all the neurotransmitters that were sequestered away in the sort of monoamine theory of depression were all forced back out into circulation, and that was why you had this sudden improvement in mood. Animal studies have suggested epigenetic effects. The more recent evidence that everybody's starting to get quite worked up about, in line with this whole new idea of neuromodulation that the others will touch on, I'm sure, that it increases brain plasticity, that it actually causes new dendrite formation. There's also suggestion it stimulates neurogenesis by promoting stem cell proliferation. In summary, then, it is extremely safe. Consider this my advance directive for those trainees here. If my depression, which I've had in the past, does get worse in my 70s or 80s and you end up treating me and I'm really bad, don't hesitate to give me ECT, please, really. It is extraordinarily effective for depression, catatonia and treatment-resistant mania to a degree that drug companies desperately wish that they could come close to. It is useful in treatment-resistant schizophrenia and arguably should be more employed as an agent for those treatment-resistant. And in actual fact, I am referring a patient today from my day job on Mill Harbour PQ, who's a chap with schizophrenia who's been in hospital for 3 months on augmented clozapine, not getting at all better. We'll be hopefully bringing him in later this week. This treatment is unfairly stigmatized. And I guarantee you, because I had it when I was invited to come back and start doing ECT. I first did it as an SHO 20 years ago when Geoff asked me a few years to start doing it with him. And I was aware that I was still carrying the stigma of it. We are not using this treatment as enough. You will be carrying the stigma in your head. It's all over the news, the anti-psychiatry lobby. This is the poster boy for anti-psychiatry hatred of our evil, conniving, bastard profession of evil villains that we all are. It is underused, in my opinion. If you would like to make referrals or discuss cases, our email address is there. Thank you very much for your kind attention.
Questions down at the end. We're going to have a panel of questions at the end of the afternoon. Wow, that's why he's our ECT lead. That's, yeah, you are.
I'm good at my job.
No, mate, you're awesome. So thank you very, very much. Keep your questions ready for Dan at the end of the afternoon. For now, we are going to move on to a talk about RTMS from Alex O'Neill-Kerr. I mentioned him earlier, but he is a visiting professor, has been a visiting professor of neuromodulation at the University of Northampton. He's been principal investigator of a large multi-center study called Bright Mind, which investigates neuronavigation and the efficacy of TMS. He's a medical director of his own company now, where he specializes in TMS, in direct current stimulation, vagus nerve stimulation, and has ketamine clinics as well. So here is Alex. I am pressing the buttons for his presentation, but I don't. I'm hoping that Charmin is going to put on. Where did you get your?
Very small.
He is very small. He's going to get bigger. He is going to get bigger.
Hope so.
Well, yeah. Everybody looks. It's pretty awesome. Hang on a minute. Right. Come on. Yeah. Right, hang on. I'm not pausing the recording, but how do I get you?
Stop sharing.
Where's the stop?
Don't stop sharing.
Should I just run outside and go Charmin sort it out? Stop video. We're just coming, Alex.
Okay, no problem.
I'm terrible. I just wish I had better.
I find things tricky in the extreme, especially if you're trying to do show a presentation as well as the person talking.
Oh,
Oh, there,
what did you just do?
I clicked back on this and then there you go.
They told you how that works. They didn't tell me how that works. Okay. No, for Charmin, that's all awesome. Right. Now I'm just going to. Awesome. Okay. Now, Alex, here is your presentation. I will be your presentation architect or conductor.
right. Thank you very much. You'll be my clicker.
Yes.
So I thought I would just kind of give a broad overview of repetitive transcranial magnetic stimulation, TMS, which is the Transforming Mind Solutions also is TMS, as are the three dogs we have, Tara, Mudra, and Shauk. So there's all sorts of connections with TMS. If you can have the next one. So neuromodulation is a kind of a newer concept. The idea is that you're increasing connectivity of the depression network on the left, and we'll get into some of why we think that's on the left. And then neuromodulation of NMDA neurons with ketamine, which I'm sure Rupert will cover in his talk. And you get the release of BDNF, which I always say is a bit like miracle growth of the brain, and you get increased connectivity. And this is all based on some of the work that was done years ago, where if you stimulate neurons 5 times a second, they connect. The Hebbian synapse, this was discovered by Hebbs, and if you stimulate them at 1 times a second, they disconnect. This then led on to the idea that this is how memory works. And in fact, now we're starting to see, well, actually, this is probably how depression works. So we've always known the catecholamine theory isn't really up to anything, and just falls apart whenever you poke at it. We also beginning to think now that ECT works through neuromodulation as well. There's some promising ideas about connectivity happening in ECT. So I have the next one. So these are the sort of places that we're looking at: prefrontal cortex, the dorsolateral prefrontal cortex, and the limbic system. And just reminding you that the limbic system, the hippocampus, thalamus, and the amygdala. And a medical student gave me an acronym to remember that. He said, think of it, the acronym of a hippo with a hat on. So any of you going into exams, think of the hippo with a hat on, and hippocampus, amygdala, and thalamus will come immediately to your mind. Next, please. So neuromodulation in non-depressed brains, if you do fMRI, you can see lots of activity on the left and the right. There's no difference between the left and the right prefrontal cortex. In depressed patients, the left prefrontal cortex is underconnected, according to the sort of Hebbian model, and the right prefrontal cortex is overconnected. Now we think, or we know that the right prefrontal cortex is where the non-reward system of the brain resides, and if that's overstimulated, you're going to get anxiety. But worse than that, you then get that overactivity hopping over the corpus callosum and then dampening down the left side and making your depression worse or bringing on depression. So basically for TMS, we use left-sided excitatory TMS, booting up the brain, and right-sided inhibitory TMS can be quite effective as an anti-anxiety agent. Next one, please. So if you see on the right-hand side, this is the non-depressed brain, lots of orange and yellow, lots of activity going on. And the right-hand side is the depressed brain, left-hand side not doing a lot because it's underconnected, and the right-hand side is overconnected potentially. So next slide. So if you want further information, Sudhir and I co-wrote a chapter in the 4th edition ECT handbook. Next slide. This is genetic testing. I thought this was an interesting one. I just wanted to kind of make you aware of. I'm doing quite a lot of genetic testing, and what it kind of takes the guesswork out of using antidepressants. And you'll see on the right-hand side, the 2 green bars are showing which 2 antidepressants, based on this particular patient's genetics, would be the right or could be the one with the most efficacy and the least side effects. We published a couple of posters on this. We published one poster on this in one of the Royal Colleges. So it's very interesting for the future. Next, please. So this is TMS navigation. So this is a navigation system. There's little bobbles on the coil and little bobbles on the patient, and then the cameras kind of marry those all together. New slide. So I thought I'd just go through a patient, because I think clinicians always find this more interesting than just hammering you with information and randomized controlled trials. So in terms of, I'm not going to go into randomized controlled trials because NICE have approved TMS for depression without special governance. So all the data has already been analyzed. There's no point in us analyzing it over and over again. So this was a lady who had a history of depressed mood for several months. She was signed off sick. She was a high-functioning management executive, and she had typical neurovegetative features of depression, negative ruminations, tearful throughout the interview. Next slide, please. She started having depressed thoughts and depressed mood from the age of 42. Prior to that, she was highly functional. She'd been on sertraline, but it was a low dose, but she hadn't experienced any remission. And she had moved to the UK from Turkey several years before. New slide, thanks. She described herself as always being successful, but started feeling pressurized in her job. She had a miscarriage, and this had also been ruminating on her mind during the depression. She typical neurovegetative features, no energy, not wanting to meet friends, losing her purpose, and felt worried about her job. Next slide, thanks. So she was very tearful during the interview. She told me she was weak, she couldn't cope with daily routine. She described she had hyperthyroid condition, which was treated and then left her with hypothyroidism. And she was having very negative ruminations about old stuff coming back to her. We'll all recognize that. Next slide, thanks. She didn't want to eat, she didn't want to see friends. She was waking at 3 o'clock in the morning and having difficulty getting back to sleep. New slide. So major depressive disorder, hypothyroidism, and global assessment of function of around 30 to 40%, so quite severely affected. Next slide, thanks. So we considered her suitable for TMS. We treated the depression and anxiety treatment. So at F3, which is the left-hand dorsolateral prefrontal cortex, intermittent theta burst, which is a variant of TMS, for 10 minutes, 5 days a week for 6 weeks at a dose of 50 to 60%. F4, which is the anxiety treatment, 1 hertz, straightforward TMS for 20 minutes, 5 days a week for 4 to 6 weeks. That's a slightly higher dose. There is a difference in dosing between theta burst and standard TMS. Next slide. I saw her after 15 treatments. She was less tearful and her scores had showed an improvement. So her Hamilton had gone from 37 to 32, the GAD-7 from, which is anxiety, 19 to 11. She noticed her sleep was better. This is something interesting we see quite a lot of in treating with TMS, people saying, wow, my sleep is so much better. Decision-making had improved, but still difficulty with motivation. So we prescribed another 15 treatments. Next slide. After 30 treatments, she was in remission. Her PHQ-9 went from 24 to 7. The HADS from 18 to 7. That's the anxiety part of the scale. The depression part of the scale from 19 to 6. The GAD-7 went from 19 to 3, and the HAM-D went from 14 to 0. Next slide. This is just a graphical summary of the dramatic drop. But significantly, she was now in remission. Next slide. So one of the newest, well, it's quite an old. It's been around for a couple of years now. The SAINT protocol, the Stanford Accelerated Intelligent Neuromodulation Therapy. It's always been an issue. Is it the number of treatments you give, or is it the length of duration? In other words, giving it 1 a day for 4 weeks or 6 weeks, or could you do 2 or 3 a day? And this is what the Saints did. They gave 10-minute treatments 10 times a day to 22 patients, 1 of whom dropped out, and they gave them 5 days for 5 days. These were hospitalized inpatients. And the remission rate was a remarkable, near 90%. Next slide. So currently, well, since certainly during COVID, we use theta burst because it's a much shorter duration. So 10 minutes intermittent theta burst excitatory, and 1 minute 20 seconds continuous theta burst, which is inhibitory. And then we have an OCD protocol, which is FC1 and FC2. That is the supplementary motor area, usually between 8 and 20 minutes, 1 hertz RTMS. Next slide, thanks. I don't think I'm going to go into this, but this was a slide just showing the relative costs of non-standard treatments. Do you want to move on? Yeah, I think if you move on. So brexanolone, $34,000 US dollars for a course. So let's go on to neuroconnectivity. So the connectivity diagram I'm just showing you, if you move on. This is a very complicated to me, piece of research that was done and published, basically showing there were 4 quadrants to depression. They were using advanced intelligence, computational studies together with fMRI, and they came up with basically quadrant, the blue and the purple. They respond to dorsomedial prefrontal cortex. And the cluster 4 and the cluster 2, which is the black and the red, respond better to standard F3, F4. So just if we can move on, that's just really to show that there is some interest now in what is going on in terms of what's going on with the connectivity. So what it kind of means is that if you do F3, F4, which is the standard one that everybody does, in America certainly, and they're not getting better after 10 or 15 treatments, you could go dorsomedial, which is just above the Bayesian, 25% of the Bayesian to Indian, and you give an excitatory treatment there. That's the one that Jonathan Downer in Canada likes doing, and has published an awful lot of data on that. Next slide. We just use a standard EEG cap to find the placements. It just gives us better placements than all these other ways of measuring. Next slide. So quantitative EEG mapping is something we've also started experimenting with. This is basically you take a standard EEG, you put it through some software called Loretta, and it comes out with a sort of heat map of what's going on in the brain. Next slide. So this is a patient we presented at the college meeting in 2022. She presented with depression and responded to standard TMS, but left her with really bad OCD symptoms. So the Y box was 34 out of 40 at the start of treatment. She was unable to shower without mom being present in the bathroom. We did a QEEG because we weren't sure where we should go. Next slide. So this is her QEEG, and what it shows in the supplementary motor area, all that red stuff, that's hyperconnectivity. I then had a discussion with another consultant psychiatrist. We looked at the literature, and there was emerging evidence of using inhibitory TMS to the area FC1, FC2, which represents where all that red blob is. So we gave her that inhibitory treatment. Next slide. And the Y box reduced to 12 after 10 treatments. And the mother didn't have to be in the bathroom at all. And she was now planning an overseas holiday, and she was going to go back to her CBT because she felt she could think properly again. Next slide. So we did the QEEG again, and you can see it's all gone green, where it used to be red, coinciding with the reduction in her symptoms. So it's interesting that people were talking about using fMRI data to determine where to place the coil. So the Bright Mind study was designed to use navigation, do an fMRI on a patient, decide which part of the left-hand side of the brain was the most inactive. That would be given, patient would be given theta burst, and then the control group was a group that just used F3, standard F3 placement, TMS. And TMS and theta burst have got plenty of evidence that they're exactly the same. There's no difference between them. Next slide. So that Bright Mind study, I'm aware, is in the process of being published. I'm not sure whether it has been published, so I can't necessarily tell you the details of the data because I might get into trouble. But look out for that. That's published in Nature Medicine. Next slide. So just more pretty pictures, depression and anxiety. Next slide. So quantitative EEG mapping may tell us, or could give you a clue as to where things might be going wrong. fMRI is increasingly being used to determine TMS targets, but and the Bright Mind study is, well, it's the biggest European study on TMS, about 200 patients. Not sure that we reached 200, but it's a big study in comparison to other TMS studies. So look out for that data when it becomes available. And just for people who are interested in setting up clinics, we do have a franchising process, and there's the email address if you're interested. The idea would be, I get a lot of people coming to me saying, well, I'm going to set up my clinic, not sure how to do it. Can I take your paperwork? Well, yes, you can, but it's a lot of work, and so we're now going to franchise that part of the operation. So thank you very much for your time, and I think we were going to take some questions at this point. Best advice I can give you, and I say this to people, what do I do when this? What do I do when that? Say, treat TMS as if it was ECT and think of what would you do in an ECT patient, basically. So yes, relapse the same as ECT, it can happen. About 20% of patients come back. for either what's called top-up, which is if you've been in remission, we give you 3 or 4 or 5 treatments, you get remission back and off you go. That's about 20% of patients. Those are really young patients that we do that in. If you're over 60, where the brain isn't as plastic, we probably do maintenance or continuation treatment, which is basically trying to do 1 treatment a month, the same as you would kind of do in ECT. Sometimes we would convert if patients are continuously coming back for top up. We might say, well, actually, might be better if we just gave you maintenance TMS now. We're looking at whether TDCS is helpful in this process. I'm not entirely sure, but we haven't looked at it in any great detail. So yeah, cut off at 60. Usually, if there was a more severe illness, probably maintenance. Again, what would you do in ECT, essentially?
Alex, I was just wondering, actually, if you could tell us, you've mentioned things like the areas like F3 and F4.
Yeah.
Could you tell us what those are? Because they are part of connections, networks. Can you give us an idea about what a network is? Why do we need to be modulating networks? Right.
So what's interesting is, so those are the standard 1220 EEG markings. So FC is frontocentral. So you've got an FC1, FC2, FC3, FC4. The F3 is on the left-hand side, and F4 is on the right-hand side. FC1 is frontocentral, so that's the supplementary motor area at the top, sort of in the middle, on either side of the corpus callosum. So why are we treating networks? That's a really interesting question, because we think that basically what's happened in the depressed brain is that the connections have become disconnected. Why they became disconnected, we don't know. But we know that that's one of the basic principles of how the brain works, and especially memory. And then basically the symptoms of the depression are the absence of the function of what that part of the brain does. So the prefrontal cortex, where executive function resides, is where you get decision-making, complex task activation, communication, and short-term memory. So people with depression come in, they say, I can't do anything, I can't get motivated, I can walk around, but I can't actually do something. I just can't do it. Why? Because the part of their brain that does that isn't working. I would say it's like having an app on your phone that you call up I want to do have a shower app, comes up, it says no network connection, and it shuts back down again. With a huge amount of effort, you can overcome it, but it's very debilitating. Can't make decisions. They don't want to go to the supermarket, everything. They just can't make decisions. I get executive type, high functioning individuals who, when they're depressed, will take all the complex emails and put them in a rubbish bin somewhere, because they don't. It's not even that they don't know what to do. They can't even read the email. They can't even understand what the concept of the email is, because their brain isn't doing what it should do. Then you've got the limbic system, where short-term memory is long-term memory, the hippocampus. You've got sleep, appetite, sexual function, anxiety, depression. So for me, and you see this in patients who are having TMS, they don't communicate. They don't want to go out. They don't want to see anyone. The first thing you see usually is they start communicating, usually by week 2. They start talking to people and chatting and what have you. It's very interesting to watch. And the next thing that happens is you get complex task activities activated. That's week 3. We call it the baking week, because people just start baking, cooking, doing stuff that they haven't done for months or even years. Then decision-making coming back in the 4th week, and so on. So the idea is that these networks have become disconnected. We don't know why they become disconnected, but we also know from stroke research that if you have a stroke in your left cortex, that is going to cause your right arm to become weak. Okay. The network, the neuron, the upper motor neuron, the interneuron, and the lower motor neuron all exist. They're still there. It's just the actual first neuron, the upper motor neuron, can't fire. Okay. So, but if you put a magnet over it and you could get it to fire, you would get activity in the arm that's now got a stroke. And this is kind of what they're now doing in stroke research, using TMS together with physiotherapy to kind of to stimulate the muscles in the arm that are affected by the stroke. But then you get all the haptic responses and the proprioceptive responses coming back through the system, and the brain now is now happy that I'm getting signals back. Because what happens in stroke is on the other side, because there's no signals coming back, the other side tries to compensate. So the right-hand side of the brain now increases in size because it's trying to compensate for the fact that the left-hand side part of the brain isn't getting haptic and proprioceptive responses back from the arm that's now affected. So we use TMS, inhibitory TMS, to reduce the size of that, because what it's doing, becoming bigger in size, goes over the corpus callosum, and then it dampens down the already damaged bit of the brain. So there's quite a lot of work in this sort of idea of what neuromodulation is, and that the brain knows what to do. You just tell the brain, look, 5 times a second, 10 times a second, the brain says, oh, better start connecting. Once a second, and it disconnects. That's it. That's the basic principle. But the brain does all the work.
I interrupt you a minute. So I'm just going to say, is that so? Basically, we are trying to use there's a few faces in the audience. We're trying to use magnets to generate electricity, a bit like the old sort of physics where you put a moving magnet next to a wire and it makes a little bulb light up. So essentially, we're saying we're using magnets to make electricity happen, and the electricity happens at the speed with which we fire the magnet.
Yeah,
that's sort of what happened.
Well, yeah, I mean, one of the 4 fundamental forces of nature is electromagnetism, and Faraday and all those people sort of found out that it's a wave of magnetic energy together with a 90-degree angle of another wave of electrical energy. So the two are interchangeable, exactly as you say. In fact, what we're using is an electromagnet, is the magnet that we use in the machine. It's about 1.5 Tesla, so it's about the strength of field strength of a CT scanner. So it fires a very small pulse of magnetic energy, which goes straight through everything. Not unlike ECT, where the skull, the skin, and everything else is an impedance. Not with magnetic energy. It goes straight in, and it hits the outer part of the brain where the cortex is. So the cortex is the sort of the bit that's on the outside part of the brain, the newest part of our brain, has 6 layers and is about the size of 3 playing cards. So often it's described as if you took a pancake and you sort of draped it over a plastic brain, the pancake basically represents the cortex. Okay, so that's what we're stimulating. The thing is, the dorsolateral prefrontal cortex has connections all over the brain, but some of them are A roads and some of them are motorways. Like there's an M1 connection going from the dorsolateral prefrontal cortex to the frontal cortex, to prefrontal cortex. And there's another big motorway, whatever other motorway, the M40, down to the limbic system. So we're just using the happenstance that the dorsolateral prefrontal cortex is like a routing station. It's like a telephone exchange, if you want to use the other kind of terminology from my day. So it's basically just routing information in and out and sending it off. But if you stimulate, so one of the things we do, or some people do, is what's called resting motor threshold. They put a magnet onto the motor cortex. Remember the homunculus. The arm is about 5 centimeters down from the vertex. So you go tick, you send in a pulse, and then you get an adduction of the opposite finger, thumb. Okay, so it's gone down the upper motor neurons into the interneuron, down the lower motor neuron, into the adductor pollicis longus, and you get adduction. So you fire up here in the brain and you get the action somewhere else. So every neuron in that network has all fired. And basically what happens, the magnetic energy, because the neurons are susceptible to magnetic energy and use electrical energy in a slightly different way with ions and ion transfer, the magnetic energy pulse then makes the neuron fire an action potential. That's how we think it works.
Thank you so much, Alex. That's wonderful. I think we've got one more question here.
Thank you. Can I just ask, in the case example you gave, it said 50, 60, 50, 70%. I was wondering, is that a proportion of the motor threshold?
Yeah, so that's the output. If you think about your, like a thymatron machine, you set the percent energy that you're going to deliver to the patient. So those are the energies those are the magnetic energies we're delivering to the patient. It's based on, well, it's based on resting motor threshold. For TMS, it's 120% of the resting motor threshold. So, you know, it then gives you roughly where you need to be in terms of what percent you need to give the patient. The only thing is, I would say about TMS, unlike ECT, we're trying to give the lowest dose possible because we know that the side effects are proportionate to the amount of energy you deliver into the brain. And in TMS, that isn't the case because there are no side effects. Well, headache sometimes, and in the early days, seizure, but this was in people who they didn't screen properly. I mean, the other thing I saw somebody said, is there any contraindications? The main contraindication is any metal in the head, near the head, so like cochlear implants, that sort of thing. Pacemakers are fine as long as it's about a foot away from the magnet. Magnetic energy energy goes down logarithmically, so the further away you get from it, proportionately it's less and less and less till it's nothing, about 30 centimeters away. So
Alex, so I'm going to have to interrupt you there for a bit. Well, in fact, we've actually nearly at time. So I'm going to have to say a huge thank you to you for giving this talk.
This afternoon now, we're going to be talking about using ketamine for treatment-resistant depression. And we have Rupert McShane to present this talk. Rupert leads the Interventional Psychiatry Service at Oxford Health NHS Trust, ECT, TMS and ketamine. The ketamine service now includes an online group preparation and integration session incorporating psychotherapies into the treatment that are given, and that's something that Sylvia is going to be talking to as well later on. Rupert's team also run an international ketamine journal club on the 2nd and the 4th Tuesdays every month, a consultant peer group for those interested in ketamine or TMS, and a biannual conference where I can share the online address, which is also on the main slide. Rupert is particularly interested in what it would take to scale cost-effective treatments for patients who would otherwise need ECT. So this is what you're going to talk to us about now. Thank you very much.
Thanks very much indeed, Geoff. Thanks for. Can you hear me at the back? Okay, great. Okay, this is what I'm going to talk about. Does ketamine work for depression? How do we use it in Oxford? How does it work? What we've learned, and is there a route to wider use in the in the UK and in particular in the NHS? There'll be a few slides that I'll skip over just because I'd like to leave as much time as possible for questions afterwards. As Geoff says, there are various extras that you can get involved in if you're interested, and I'll show this slide at the end, but essentially just search for ketamine conference. There's a fantastic conference about to happen in Oxford. 48 of the world's leading speakers are coming to talk for 2.5 days about nothing but ketamine for psychiatric disorders. It's bliss. Okay, so first things first, does it work for depression? Well, the fact is it's licensed, so it's safe and effective. You know, that's the top and bottom of the argument. So this is the Spravato data, just to go over this very quickly. to get a license, you have to have 2 positive trials. 2 of the 4 trials that were done in phase 3 were positive, 2 were not. So Transform 1 with a fixed dose of S-ketamine was, there was no difference, significant difference between placebo and the active drug, and certainly no difference in the remission rates. And in Transform 3, which was in the elderly, there was really no separation until right at the very end, and this was overall negative. So the license was awarded on the basis of 2 trials, Transform 2, where there was a variable dose of Spravato or S-ketamine nasal spray, with about a 17% difference between drug and placebo in terms of response, and about a 21% difference in terms of remission rate. So that was the first positive trial. The second positive trial was Sustain 1, where people who were remitters who had TRD, treatment-resistant depression, were randomized either to continued Spravato here in the green line or to placebo, and the ones in placebo relapsed more quickly than those who continued with the S-ketamine nasal spray. So, and there are countless other trials that suggest that ketamine is useful as an antidepressant, but that has a rather short benefit. Why have NICE rejected nasal S-ketamine? Well, essentially, it's expensive, and there are uncertainty about the current costs of treatment-resistant depression, and that makes it difficult for NICE to actually establish what the advantage compared to current treatment costs are of S-ketamine. Just to give you an idea about this, the S-ketamine nasal spray, the cost per quality has been listed at about 55,000 per quality. You have to get under 30,000 to be sort of within range of what NICE will approve. The cost per dose on the list price is £489. When we're using it in clinic, we're typically giving 7 IV doses out of a vial that might cost us £7. So it's about £1 a dose. And so not surprisingly, that looks a good deal more cost effective, although of course a lot of the costs are tied up with actual administration of ketamine. So there have been various backwards and forwards to NICE, as well as the expense. Another issue is where it should be used in the pathway, and a recent trial published in the New England Journal compared S-ketamine with quetiapine, and essentially what that showed was that the primary endpoint, which was remission at week 8, showed that the S-ketamine did slightly better than those on quetiapine. So this is in people who've had 2 antidepressants and then augmented with quetiapine in that usual sort of hierarchy of what you would use in treatment-resistant depression. And the same thing for the sort of key secondary, where people were remitted at week 8 and relapsed free through to week 32. Anyway, this is the subject of continued appeals, and we'll see where that gets to. So how do we use it in Oxford? Well, we have, as Geoff was saying, there are 3 elements to our interventional psychiatry service: ECT, ketamine, and TMS. In December, we saw about 100 different patients, treated 100 different patients with ketamine, with about 140 infusions. Our current ECT caseload is 1, and TMS we're treating 4 a week, 4 a day roughly. That gives you a sort of idea. So the ketamine stream, we have 2 streams. One is paid for, which happens on Monday, Wednesdays, and Thursdays, and we take referrals from GPs and psychiatrists from across the country. The NHS stream, we're only for local people, and they have to be referred through secondary care to us, and we treat them on Tuesdays and Fridays. We get a lot of background information before assessment, and you can see it. There's a very detailed website. This is what it looks like. So this is just a standard ECT recovery bay. So we've got curtains between the patients. In fact, we've now expanded with another 3 beds in a sort of glass pods that are more, much more private. So we've got 6 beds running at the moment, and typically we'll treat 16 patients a day across those beds. So the process is that we'll start with a triage and then do an online assessment, and then patients who come through to treatment will start with an online preparation session group before going on to have 6 to 10 infusions. And then really the key for this whole thing is what happens with maintenance treatment for the people who respond. So typically we're looking at a maintenance schedule of every 2 to 8 weeks. And then sometimes people need rescue infusions as well. And sometimes we have people having oral ketamine at home once a week on the weeks between their infusions, if that makes sense. So it's a way of trying to eke out the benefit. They also go through to have, they can come through to have online group therapy. And we've got fantastic supervision from Rachel Gibbons. And we have an online psychodynamic group as well. It's a slow open group just for about 6 patients. So the large majority of the patients don't come through to psychotherapy at the moment, but we've set it up so that we've got that facility running. And essentially we now have 3 clinical fellows who lead that team, and they come between their CT3 and their CT4, and they do a year with us. Essentially it's a sort of fellowship in depression, where they have the 3 modalities. And we also work with drugs as well. So so the models of administration, well, we have this hybrid model I mentioned. So you start with a series of induction infusions. The patient's QIDS score goes down as they get better, and then they have a sort of series of maintenance infusions. And in this case, you can see the patient has gradually relapsed as we've tried to increase the interval between the oral doses, and then they've had some rescue IVs. Other models include just obviously the nasal S-ketamine, and it's worth knowing that the commonest interval that people have between their S-ketamine doses in the long-term follow-up from the trials of S-ketamine is weekly. So the vast majority are weekly or 2 weekly, and of those, more are on weekly than 2 weekly. I'll just say a little bit about oral telemedicine later. So in that induction phase, it's quite common for the dose to gradually start. The starting dose of racemic IV ketamine is usually 0.5 milligrams per kilogram, as you can see here. And then gradually the dose over those 6 visits would increase as we titrate to the point of dissociation. And we're looking really for people to get a sort of floaty feeling, thinking that their mind and body are separate. Look at their feet, and it seems as if it's not part of them, rather than getting to a sort of ego dissolution stage, which is the dose, which is what you see at higher doses. And that's the sort of sense that you're like being a drop of water being dropped into a river. Okay, so or being like a tiny atom in a big universe, that sort of thing. So that's sort of what we're heading for. And in our clinic, so this is our current caseload. We had the first patient who came back for their 10-year infusion last week. This is the median duration of treatment in our clinic is 2 years, but obviously as we go on, that's going to go up because people can keep coming back. And you can see here that the majority of what we're doing is self-pay, and that 77 pays for that 22%. So in terms of the patterns of maintenance use, we've got about 140 on our caseload, and at the moment 102 of those are receiving regular IV ketamine, and of them 60 are receiving regular oral ketamine. So you can see that some have just IV, but the majority also have oral ketamine. And how often are those IV infusions? Well, the average interval is between every 3 to 4 weeks. And in terms of oral ketamine that we give people, we tend to supply somewhere between 1 and 6 doses in the form of a liquid bottle. It's supplied from a pharmacy in Newcastle and sent to their homes. Sometimes we supply it through the hospital, but usually that's the model. And our sort of maximum that we think of is about 300 milligrams. And they have a test dose in clinic first so that we can see how they respond to it, and then we may need to gradually increase the dose, but we're confident that they're not going to get any sort of adverse effects. So what happened to those people who were referred in 2022? We had 70 referrals from a GP or psychiatrist, and Of those, we assessed 41. And when we assess people, the large majority do tend to come through to have an infusion. And I'll talk a bit about that later. Of those, 10% had such a good response that they just went off into the sunset cured. There were some that dropped out due to poor response or to side effects or to cost or transport. That's obviously, those are big issues. And so 55% of those who started ketamine with us are still in treatment. And of those, 40% are in, those who started treatment, about 40% are in clinical remission or had a marked clinical response. And about a further 15%, just 6, are sort of think that it's worth coming and they still pay for it, but they're struggling. Okay, so one of the things that happens in the clinic is that, of course, the patients that do really well, they go off and you don't really see much of them. So it's just the same. You always end up dealing with the difficult patients. So it's not a way to stop dealing with difficult patients. They just keep coming. What about side effects? Well, one of the problems that people worry about is urinary side effects, and we tracked this over in the first 279 patients. And basically what this graph shows is that, so the change in BDI here is the change in Beck depression inventory, and you can see that the majority have had a reduction in their Beck depression inventory here on the x-axis. Okay, so very few have had an increase, but there are, oh, hang on, I've got that the wrong way around. No, these are the people whose IPS, whose bladder scores have increased, and there's just a few that have had quite a marked increase in their scores. So we've looked at those cases, and essentially 1 stopped due to urinary symptoms, 2 stopped due to a lack of effect, 3 continued with long-term, 1 had bladder cancer that obviously preceded the ketamine. The long and short of it is that actually I don't think that at the medical doses that we're using, there's really a significant problem. Occasionally patients complain of sort of lower abdominal pain and dysuria. Usually that's, I mean, the causes of that are legion, but we haven't had any where it's really been clearly due to the ketamine. Okay, so I don't even, we've stopped actually doing this regular bladder inquiry questionnaire. So how does it work? Well, there are lots of different ways of answering that question, and I'd like to go through some of them because I think it's actually interesting, but I can't go through all of them in the time that we've got. So it essentially at a molecular level, it blocks the glutamate receptor, the NMDA receptor, causing a glutamate surge. There's then a cascade of molecular activity in the postsynaptic neuron that results in an upregulation of AMPA receptors in the synapse, and I'll talk a bit about neuroplasticity. It blocks the lateral habenula. I'll talk quite a lot about that, and reduces default mode network firing, which can be increased which is typically increased in treatment-resistant depression. And then there are a variety of psychological ways in which it might work. It might be a placebo effect or expectation bias. I'll talk about that. It may change people's perspective. I'm not going to talk about that, although we might talk about that later. It obviously can cause relief, and then there's an issue about ruminative ruts and blocks. And I'm particularly interested in what it does to social thinking, because I think that depression is fundamentally a social illness, and I'll explain a bit more about that. So just to rehearse that, here's an NMDA receptor. It's a channel blocking antagonist, and let's go. So, and here's a way of sort of describing how it might work. So if you imagine that this pink neuron here helps you to get out of bed, then when it fires, you can imagine that it is controlled by this interneuron here, and which might project its GABAergic synapses onto this first part of the axon here, or indeed onto the cell body, and switch this off. This interneuron itself has a glutamatergic input onto its dendritic tree here. And this is the presumption is that ketamine blocks by working at this presynaptic this level by blocking this NMDA receptor. So by inhibiting this excitatory input to the interneuron, you reduce the veto that this interneuron has imposed on this getting out of bed neuron. Okay, so when you do that, suddenly everything flows, you can get out of bed more easily, your sclerotic thinking seems to flow much more easily. Now, of course, ketamine is also an anesthetic, and if you increase the doses high enough, you'll switch this off and you won't be able to get out of bed out of all, let alone your bathtub. Okay. I'm not going to talk about this, except to say, I mean, this is sort of scary slide. But actually, I will talk about this a little bit here. So this is the sort of neuroplasticity angle. So this is a dendrite in a petri dish. This is a depressed dendrite where there's rather little of these dendritic spines, and it's on these spines that the synapses occur. And in depression, they sort of retract, and there's fewer of them. Whereas after a slug of ketamine, you get these spines sort of rapidly emerge from the dendrites, and that provides an opportunity, rather as if you envisage it as a tree in winter, the depressed dendrite turning into a tree in spring. So the terminal arborizations that allow synapses to form are increased, but obviously in order to make use of that, you have to have flow of information through those terminal arborizations to consolidate the connections. One of the things that happens, of course, when you're depressed is that you rehearse your negative cognitions endlessly. They go round and round and round. You get really good at them. If you rehearse the violin as much as you rehearse your negative cognitions, you'd be a virtuoso violinist. Okay, and that's something I say to patients, and they sort of, oh yeah, I'm a virtuoso at this, aren't I? I'm really the best. Sadly. Okay, so those are some of the metaphors that I think are helpful. The lateral habenula is something that I have only really found out anything about in the last few years, and it's a tiny area that is essentially an anti-reward center. So it fires if you're disappointed, if you're expecting something nice to happen and then it doesn't. Ooh, that sinking feeling. And of course, there's a parallel in that we have a reward center that if you press the lever, you'll press it until you starve if you're a mouse. So that's in the nucleus accumbens. So it's sort of the opposite of the nucleus accumbens. And so when it fires, it makes the mouse unhappy, and then when you can block it with ketamine. Okay, so this is a key part of how ketamine works. It blocks the anti-reward center. And if we just look at the connections of the lateral habenula in a bit more detail, so on this diagram, we're looking at the right-hand half of the brain. This is the front, this is the back. So we're looking at the medial surface of the right-hand half of the brain. This is the corpus callosum here. These areas here in brown are the areas of the default mode network that commonly fire together when you're not doing much, you're just daydreaming. Here we have the lateral habenula, and what you can see is that its outputs are essentially to the dopaminergic, to the monoaminergic nuclei that we know are important in affective disorders, the raphe and the ventral tegmental area substantia nigra, the input to this is from the medial prefrontal cortex and the lateral hypothalamus. And there's also feedback to that area. So this is an important area, and I'll come back to it in just a moment. Okay, but before I do, I just want to address the question: is this all expectation bias? So this was a study that was published recently, in which patients who were depressed and coming to surgery were randomized either to have ketamine during their surgery or placebo infusion during their surgery while they were unconscious. And then their depression was assessed directly afterwards, day 1, 2, and 3 here, out to day 14. And what you can see is that both the placebo arm and the ketamine arm, they both had a big reduction in their depression scores, but there was no difference at all between the two groups. So there are 3 possible explanations for that. One is that the whole thing about ketamine is just one big expectation bias, and that there's no real effect. The second explanation is that you need to have a conscious experience of dissociation in order to benefit from ketamine. And the third is that actually the anesthetics themselves, which are often known to be antidepressant, things like propofol is an antidepressant effect, that these in fact imposed a ceiling on the ability of the ketamine to show its additional antidepressant effect. And this is which of these is correct is currently an open question. Yeah, so the ruminative ruts. Okay, so one of the metaphors that I use is that as I mentioned, you know, as you think your depressive thoughts, they get stronger and stronger. You're digging yourself into a rut. What ketamine can do is it can, if it removes you from that depressive round of thinking, then obviously gradually the rut will silt up. But the rut remains there. It's a deep scar. It'll take a long time for it to heal. So you know, one has to manage expectations about this. Very easy to fall straight back into it. So this next bit is a bit speculative, all right, and I hope you'll bear with me. Okay, and this is the work of a Chinese group looking at mice. I'm generally not very excited about mice, about animal work, but this is somehow, I don't know why, but it's really caught my imagination, so I'm going to tell you about it. If you put 4 mice into a cage and they're genetically identical, they will develop a pecking order, a social dominance. Then they'll be ranked 1, 2, 3, and 4. If you stick your dominant mouse into a tube here, then it will force out the non-dominant mice. And as it does that over successive trials, it gets faster and faster at forcing the mouse out. It presses hard, it pushes the other mouse harder, and the mouse that's a loser gives up quicker. Okay. If, however, you rig it so that the dominant mouse can't push the non-dominant mouse out, and the non-dominant mouse eventually wins, then what happens is that this dominant mouse gets depressed, and its position in the social hierarchy is back in its cage is dramatically reduced. So it goes to from being kingpin to being number 4 mouse. Okay, and so this is forced loss. It's not natural loss. And what's important is if you put the top mice, the dominant mice, from different cages and you set them against each other, and this dominant mouse loses in those contests, it doesn't get depressed. It doesn't get pushed down the social hierarchy back in its own cage. Okay. And so that experience of losing means that instead of being able to hog the warm spot in its cage, it gets forced off the warm spot. So it's sort of, and similarly, if it's sort of, in terms of staying alone in the cage, it spends more time alone, and it spends more time being chased by the other mice if it's being knocked off its perch by this unfair fight. And what's interesting is that the lateral habenula fires more during forced loss, and the lateral habenula continues to fire over time. So you can see that here, the forced loss mouse, the bursting frequency of the lateral habenula continues to remain elevated, but it doesn't when you've got natural loss. Okay, so and then the extraordinary thing about this, you know, it's all published in Nature and Science and Cell, journals I can't really understand, but, you know, very rarely read, but actually it's really well written. Recommend it to you. But one of the things that they do, for example, is that they can stimulate a particular area of just medial prefrontal cortex, and by doing so, the mice regain their position. So they're pushed up the hierarchy, back through this manipulation. So this is a talk about ketamine. What's the relevance? Well, the thing is, ketamine does the same thing. So you knock the mouse off its perch here, forced loss, he's gone down the ranks to number 4, you give him ketamine and things start to look different. It goes back up the rank. However, if he was mouse 4 to start with and you give him ketamine, it makes no difference. So this has, and of course it's relevant to the placebo effect because the mice, well, you know, they didn't know whether they were going to get ketamine or not. So ketamine acts as an antidepressant in this mouse model. Just that's the bottom line of it. That antidepressant effect has an effect on social rank. But as I say, there's a political angle to this, as you can see, as to what you do about the poor 4th mouse. Just to summarize that, unpredicted loss leads to lateral habenula firing, reduced medial prefrontal activity, loss of rank and depression, and ketamine can reverse that. And now I want to go a little bit more speculative and just say, you know, our inner world is fundamentally social, okay? And it's peopled by ourselves, but also by multiple internalized characters. You know, I'm not saying anything that isn't completely obvious, but obviously, you know, we have in our heads models of our parents, our siblings, the playground bully, our mentors, heroes, you know, teams. And it would be weird if the external social battles that we fight weren't replicated internally. So actually, these internal conversations are probably some manifestation of social dominance. You could argue that they might be driven by the same mechanisms that drive our external efforts at social dominance. And so the key thing here is that the implication is that if this was right, that it would, I mean, firstly, it might explain suicidal ideas, which I think I've always thought a bit weird, but makes sense if you think about it being the ultimate way of killing your enemy. It would then make sense to focus in our anti-depression therapies, particularly on ruminations and critical self-thought, and on equalizing the ego and the superego, if you like. Now, you know, it's an obvious thing to say. It's just a different language for saying things that we all know about. And I think that using language that patients understand and can empathize with and can really relate to is absolutely crucial if you're going to get them into a therapy that they can really make use of. And so does therapy help? Do we know if therapy helps when you use it as an adjunct with ketamine? Well, there's only one trial that's really looked at this, and that was in alcohol use disorder. And it's a factorial design. So the patients either got ketamine and psychotherapy, or ketamine and psychoeducation, or placebo and psychotherapy, placebo and psychoeducation. And sure enough, the patients that got the ketamine and psychotherapy did best, and the patients that got placebo and psychoeducation did worst. But overall, in the statistics, the patients that got the ketamine did better than those that didn't, but there was no difference between the placebo and the active therapy. Okay, so whilst, you know, it'd be nice to think that the therapy made a difference, there isn't any evidence yet that that's the case. As far as I know, this is the one study that really did show a difference, and it wasn't very dramatic, but essentially what they did was, this was after a single infusion, I think they had single infusion, or was it 2 infusions? I think it was a single infusion. That's right, it was a single infusion, and patients were shown images of themselves and the word nice, or themselves and sweet, or somebody else, and neutral words. this sort of thing. So it was designed to make Pavlovian associations between positive traits and I or me. And the patients who had the positive traits did better overall and did better for longer. And it was maintained out to 90 days, but not after that, than those who received the sham. So in another language, that would be ego strengthening, wouldn't it? So what would therapy need to look like? What could it need to look like? And I think that, you know, if this model were correct, then we'd be having to say, actually, we need to have a compassion focus about self-compassion. We need to have groups that would, you know, look at social interaction, and we need to be focusing on the critical voices, and possibly giving people a self-esteem boost within 2 hours, which is possibly the window where it would work best. Now, Geoff, you need to keep me on time and shut me up when I'm going over, because I will talk and talk. How much longer have I got?
You keep going. Go for it.
So what have I learned? So in the consent process, you know, this is what I say, you know, it's going to make you nauseous, dizziness, don't drive. I talked about the dissociation, I've already said that. It's important to say that there is a risk of people feeling worse directly after the ketamine. But the most important thing is to say it's almost certain that if you respond, you will need long-term treatment. And of course, people that will say, oh, psilocybin is very different from that. You know, people don't need long-term treatment. And I'm afraid my reaction to that is, oh, bless, you know, because actually we don't have that data. It may be right, but, you know, I've been doing this for 10 years. It's incredibly exciting when patients who are so sick get better dramatically and abruptly. And of course, that's happening with psilocybin as well. But, you know, really the guts of this for people who are psychiatrists dealing with the patients is maintenance. You know, it's relatively easy to get people well. Keeping them well is much more difficult. So unless you give it again and again. So I don't know whether psilocybin you'll have to give it again and again. And I don't know if we gave 8 hours worth of ketamine and made people feel really weird for 8 hours that they would stay well for 6 months as well. I don't know. So we need to discuss tolerance, and that's why I think that this needs to be used by experienced doctors, preferably psychiatrists who are used to dealing with drugs that induce tolerance. I don't think it causes as much tolerance as a benzo, certainly not as much as an opiate. And the analogy I always give is that it's about the same as wine. If you drink a lot of wine, you'll get tolerant to it. And the more you drink, and the more frequently you drink it, then the more tolerant you'll get. So a few pitfalls. I've mentioned how it makes you feel. You know, it's fantastic. But of course, that feeling of power that you can have, you know, that feeling of, you know, it can make you feel a bit omnipotent. Make you feel a bit like an orthopedic surgeon, you know, and so you know it's sorry to be non-woke, but so saying no to patients, so that's one thing. But of course the patients they're absolutely desperate to have this stuff, and if you say no, it can be really catastrophic. In a sense, if you think of it in the social dominance hierarchy, you've pushed them down again. You push them further down the hierarchy. So I tend to say, you know, by the time it's easier to, I'm an old age psychiatrist by training. So, you know, patient with dementia meets a door, they'll turn around and go away. Patient with dementia meets a person saying, go back, they'll have a fight. So it's better to say no right at the beginning and to try and triage people out. So I give them strong advice and say, you know, if I was in your shoes, I don't think I'd do this, but it's up to you. If you really want to, that's fine. So I'm giving them choice, retaining choice. But there's also a problem of not saying no. Obviously, you've got people who've got chaotic lives who, you know, might have had past histories of substance use, and particularly people who are taking on people who can't then afford it. So we've, you know, we have to have an eye to that. And then there's the whole issue of dependence on the team. You know, it's easy to come along, feel better rather briefly. And there's a sort of passivity to that. And if the social situation is so dire that even, you know, that functional wins seem impossible, even if you feel a bit better, then it's very hard for that to be maintained. So I think, you know, and and I don't have a solution to that. You know, that's a political issue. There are issues about how you jointly manage patients, but we won't go into that. In the maintenance phase, it's possible to get escalating doses and to need more rescue infusions. So the way we manage relapse is we bring people back and give them 2 or 3 infusions in quick succession. So, for example, I saw a teacher yesterday. She does fantastic work in her classroom. She tries to come back at half term. She's so dedicated she won't take time off, but it's just a bit too long for her. And so when she comes back, she's not quite, sometimes she's relapsed badly and needs to have 2 or 3 in quick succession. Whereas if she had just a slightly shorter interval, we'd be able to maintain her. That's the sort of thing we have to deal with. And in US, there's a practice where people are just treated in some companies that now do oral ketamine, send it out by post. All the consultations are online, and they send out medicine to be used. So in one company, they say, put it under your tongue and then hold it there for 7 minutes and then spit it out. There's a nice letter in the American Journal this month which describes a patient who didn't spit it out, swallowed it, then had the paramedics round because she'd stopped breathing or nearly stopped breathing. She had lots of secretions. They gave her some atropine and she woke up and it was fine. But the ketamine levels in her blood were higher than those in Matthew Perry, and certainly higher than you get for anesthetic levels. So, it's all in the dose. You can see here this patient was sent 1,200 milligrams, and I mentioned that our maximum was 300. So what about the feasibility of a ketamine clinic operation? Well, when we had 3 beds, we'd treat 9 to 10 patients a day. If there wasn't any ECT going on, if it was happening on the Tuesday and Friday at the same time as ECT, we'd treat an additional 4 or 5 patients. So we reckon that you'd have a caseload of about 20 patients in 2 sessions. And the theoretical minimum for the staffing here would be two staff, of whom 1 is qualified. Our minimum is that we have a doctor and a qualified nurse, and usually we have a healthcare assistant as well. The main task here is the psychiatry. It's not the cannulation, it's not the giving of the dose, it's talking to the patient. And that I think is really important, because it help, when it comes to esketamine, if that ever gets NICE approved, this will be the issue, is managing the psychiatry, personalizing the dose. So I'm in the final stretch now, just 5 minutes. So the way that this is going to happen in the UK, I hope, is as an option instead of ECT, and that we're basically looking for a license for IV racemic ketamine at that dose of 0.5 milligrams per kilogram. And that's the dose that was used in 2 studies. The first is this one, or this is actually the second study, which was published in the New England Journal last year or the year before. Last year it was. So it's an open label non-inferiority study of ketamine versus ECT, right unilateral, seizure threshold ×6. The primary outcome was 50% reduction on the QIDS, and they randomized 403. There was a differential dropout in that people who were randomized to ketamine were randomized to ECT were slightly more likely to drop out. So there were people obviously who went into this study hoping that they would get ketamine, and when they didn't, they just dropped out. So that says something about the social acceptability of ECT. The primary outcome was here, the QIDS, and you can see that the ketamine, this is the percentage of patients with response, and you can see that the ketamine was definitely not inferior to the ECT. If anything, it was slightly better. In terms of other secondary outcomes, the remission at the end of treatment was higher in the ketamine than the ECT. So ketamine was non-inferior to ECT in this study. People argue about whether it was optimal ECT, but that's the result. And the key thing is the side effects. So and the relapse rates. So the relapse in the ECT group was 56% at 6 months, compared to ECT was 34% at 6 months. And really, in terms of the summary of these memory scores, is that the ketamine patients had less severe subjective memory complaints than the people in the ECT at 6 months. But that wasn't apparent objectively, and that's common. When you do cognitive studies in ECT, the subjective and the objective rarely match up. The second study was this study from Sweden, very different to the previous one in some ways, in that the first one was all outpatients, this one was all inpatients. In the first one, there was differential dropout in the ECT arm. People were more likely to drop out. In this one, people were more likely to drop out if they were in the ketamine treatment arm. And part of the reason for that was that in this setting in Sweden, they use a lot of ECT. They're very familiar with ECT. They had had no experience of using ketamine, and so they were likely to back out more quickly. But essentially, in terms of the results, the remission of ECT was slightly better overall in this inpatient group. So for remission, ECT, there was 63% remission compared to 46% in the ketamine. Similar sort of thing with response, but there was a differential here in the age. So the patients who were under 50 did better on ketamine, and the patients who were older did better on ECT. You can see here the relapse rates over a year, actually pretty disappointing for ECT. You know, so only 40% of people after a year are still well. And this here on this side, you can see that really essentially the ECT and the ketamine were pretty similar. Okay, so on that basis, you've got 2 phase 3 studies. That's what you need to get a license. They both used 0.5 milligrams per kilogram IV racemic ketamine. The side effects, same sort of issue, less severe enduring side effects with ketamine than with ECT. That's the basis on which we're going to go to the Medicines Repurposing Committee to ask for them to consider the possibility that this could be awarded a license. And that's the beginning of the story. There's a lot of hoops that would have to be jumped through, but that's the way I see this getting into NHS practice. And just to my final slide here is just about ECT use. I run the ECT service in Oxford. And the key thing here that I want you to see is the differential rate of ECT use in England and Wales compared to our European and similar other sort of similar countries. So we're about 1/10 of the use of other countries in terms of our ECT use. We are underusing ECT seriously. Thank you.
Hello, everybody, and nice to be here. A lot of what I'm going to talk is not as evidence-based as the rest. The research is not as solid, and that's one of the main reasons I'm talking about the psychiatrist trap. So just bear with me, and it will be more of a narrative rather than data. So the first thing that I want to focus on is the opportunity of neuroplasticity. Is now the hype word. We were talking about chemical imbalance before, and then the default mode network, and now is neuroplasticity. But we need to be very aware of, neuroplasticity is the ability of the brain to reorganize itself, both in structure and how it functions. And neuroplasticity is something that when I started medicine didn't exist. So if you had a brain tumor or some kind of injury, it was really hard to recover. It was almost impossible. Nowadays, we know that that is not true, that you can recover, the new dendrites form, and that happens as a normal day-to-day thing. And one of the things that happen is that it affects all parts of brain, from molecules to systems. It is involved with hormones and DNA and, all the membrane channels. And what happens is that it results from many, many activities. So we have traumatic events and we have a stress that can actually shape the brain, especially when you are younger, because the brain is more plastic. And then you have social interactions, meditation, emotions, learning, paying attention, or doing mindfulness, the diet, the exercise, and the new experiences. So as you can see, it's a huge amount of things that will affect neuroplasticity. And what is important is that nowadays we know that all the SSRIs, the ECT, the TMS, all of those are affecting neuroplasticity, and therefore it's important to keep that in mind. But it's a very high word, but it has a dark side to it. When something is plastic, or when a bone breaks and we fix it, unless we put a proper cast around it, it will heal not correctly. So, you know, and if it is constantly being used because it has to be used, it will not heal correctly. And that is something that is important to keep in mind because, you know, I mean, I never thought that SSRIs could leave somebody open to getting worse experiences or being, you know, neuroplastically more affected by society. But it's something that maybe we need to start considering. So neuroplasticity in mental illness is very much driven by neurodevelopmental components associated with polygenic risk factors. We all know about this. But then the clinical trajectories of a mental illness varies enormously. You know, you can have the same genetic making, but then, you know, the experience is experience dependent, influenced by environment, exposure to experiential phenomena. So somebody who goes out and have friends and goes and travels around the world probably is less likely to get as ill as somebody who stays in Tower Hamlets in a little house and can only go to work and come back. So the range of experience is quite important in the human development and in the plasticity and resilience building. So psychological traumas, substance misuse, social attachment, internal representation of the self, which, you know, is what Rupert has been talking about, and, you know, other socio-cultural influences such as, you know, early degree of stress and nurturing, but as well, spiritual beliefs, core beliefs, you know, how you're being brought up. So in a nutshell, it's everything. So it's very important to note that now, you know, we know that psychotherapy is being now tested. We've seen it in images, you know, longer psychoanalytic psychotherapy does affect the brain, creates new pathways. There is neuroplasticity involved. SSRIs at the molecular level, ECT with electrical changes, TMS with electrical and electromagnetic changes, not very clear for me how it works. Ketamine again has the pharmacological, but one of the things that ketamine has, which is explained here, is that dissociative state, which adds an experiential dimension to what ketamine offers. We don't know much about how that happens or what that experience is, but we know, as it's been explained, that dissociation needs to be there and we need to be conscious of it for it to actually work. And then we have meditation as well, which is purely experiential and also has neuroplasticity. All this is thanks to neuroimaging and people who are involved, you know, with maybe Buddhism or with psychedelics who have been able, and are scientists who have been able to take these images. So we're very lucky nowadays. So what we have here is certainly we have all these different mechanisms of action that we study, but they have the same outcome. You know, so experiencing, you know, learning to horse ride seems to have some similar works in the brain as taking medication. Not tested, this is very speculative and there is no data on comparing these two, but we know that both do neuroplasticity or improve or, you know, make the brain more plastic. So this is where how important it is, the psychosocial treatment. And this is where, you know, psychology comes into place, because obviously you're leaving the brain more able to be modified. And if you continue, you know, doing any kind of damage to it without providing a proper, you know, context or support or something to work with, maybe, you know, the rewiring will not be that effective. So we have a very interesting study by Georgiera in 2011 where they gave SSRIs to mice. I'm not very interested in mice either, but this was quite interesting because what happened is that they gave them fluoxetine and a good environment, and this kind of the phenotype of depression got better. And then they gave them fluoxetine and a bad environment, and that created that the phenotype of depression got worse. And what is very peculiar is that the mice that were in the bad environment without the fluoxetine did not as bad as the ones who had fluoxetine. So that got me thinking about, you know, this neuroplasticity and what is our responsibility here, as much as harnessing the potential, being aware of, you know, maybe sometimes when they don't respond, maybe we want to try something different instead of, you know, providing that openness that is not working. So again, the tree analogy. So the drug effects are context dependent. And this is, more and more clear with SSRIs and with normal medication. Anything that is more psychedelic, this is even more enhanced, because the neuroplasticity that ketamine or psilocybin or DMT can produce, it's much quicker, faster, and intense. So it's a very short period of time, but it's really, really intense. So it's important to have this in mind. Okay, so that's the neuroplasticity, the double-edged sword, and we need to consider this. So the set and setting that we talk about in when we're talking about psychedelics, which is about what is the mindset of the person when they are going to take, what are the expectations, what they hope for, plus what there is the environment around them, that is very important in this kind of medicines or substances. But I think it can also be applied for SSRI, so for more normally used medication. So it seems that we're learning backwards, not, or not, because psychedelics were there a long time ago. So I'm going to talk a little bit about the relationship of the psychiatry and psychotherapy. This is, well, I didn't have it very clear. So when I studied, we all do this training about psychotherapy, and I didn't fully understand how it fitted with my role as a psychiatrist, because obviously I cannot provide psychotherapy. But it's very interesting that at the beginning of the century, when there was no medication, psychotherapy was the only way to do psychiatry. And, our tradition originally is based on this understanding of the human brain and how things affect us. When medication came in, and this is very interesting, I didn't know about this, but the amitriptyline and the first medication were used in the psychotherapeutic environment. So they were used so you could do better psychotherapy. So that I thought it was very interesting, which is almost an intuition about how things work, isn't it? It's almost, now backwards, we're seeing that there's neuroplasticity and it makes sense to do it that way. Then it was, the traditional way of doing things. Then what happens is, in the 90s, medication is used, the use of it starts to shift. The pharmacology business changed the concept of medication, which, we had tranquilizers and we have activators, to the word antidepressant, antipsychotic. And this was for commercial purposes, trying to sell a product that is much more specific and is going to give you less side effects, which in a way is true. But obviously, the idea that it is an antidepressant, it is not necessarily certain. And nowadays, we had a very interesting talk not so long ago, maybe a year ago, where it was very clear that SSRIs, the action of SSRIs is not necessarily only the serotonin. There is an action on serotonin, but serotonin is not antidepressant per se. It doesn't change the mood. What it does is improves neuroplasticity. So the idea that, SSRIs, because they were more tolerable, primary care physicians were prescribing them, so they got far away from the psychiatrist who was trained to do psychotherapy, who will have been applying psychotherapeutic models. So less and less use of psychotherapy within the psychiatric consultation room. And as well, what happens is, health services are strained, there's not enough money. So, things start to become very convenient that you don't have therapy, because then I can see more patients. So we have still the training in psychotherapy, which I'm extremely grateful for. I don't think they do that in Spain, for example. So here is a very good training to have that on top. It might not be so obvious at the beginning, but it becomes more and more relevant as you continue to practice. And it's an integrate. So the idea is that in an integrated approach, it's will help us understand. And this is what we do on our day-to-day practice. We don't just give medication. We do our assessments, we do our histories, we check what is happening. When we have social services available, we work with social services, with occupational therapy. This is actually what we do. So I think it's interesting to have a bit more of a neurological basis to why we work in a multidisciplinary team and why that is so important. So psychotherapy is defined as interpersonal intervention that relies on repeated encounters, a healing relationship, and a particular explanatory model, all within a structured therapeutic frame. Okay, this is the definition. You know, there's a lot of different psychotherapies, which is what is making research very difficult, but because everybody wants to apply their own method, and we cannot compare because they are not the same. So basically, this is what is called psychotherapy. And when we look at the research that has been done with ketamine, for example, they do have, as Robert was saying, the preparation, the explanation. There's already a relationship with the therapist. There is the repetition. There is the expectations, the exploration of expectations of what they want. There is a relationship that is healing, and it has a particular explanatory model. In the case of ketamine, it might be a biomedical model, but there is an explanatory model, and there is a structured therapeutic frame. So interestingly, any of these substances that are now being used are mostly done in the context of some kind of psychotherapy. Okay, there is an additive and synergetic effect, and this has been shown of therapy and medication, which is SSRIs, and normally we have a combination of strategies, and mostly used. So let's put it this way: we use psychotherapy for the beginning, then we use medication. Ideally, it should be with psychotherapy because it's evidence-based, but it's not, and it's on the NICE guidelines, but we don't have the capacity. And then if it doesn't work, then we try to reintroduce it again to help with non-response, residual symptoms, relapse and recurrence involving psychiatric illness. So the cases that are harder, more difficult, then we put the psychotherapy to work with that. The improvement of psychological, so we have evidence that improving psychological flexibility, quality of life, and overall functioning is beyond the symptoms reduction. This is another of our traps. The way we measure symptoms, how do we define relapse or recovery? It's based on a set of parameters that might not be the most important for the patient or the most realistic. We might never get rid of the voices, but so long early intervention services or early detection services, they work with accepting the voices rather with quieting them down. So there is a shift in understanding things. We're doing it somehow on the outside of what the research can show us. So research is very important and keeps things safe, but it's important as well to see what research is missing out. So yeah, they also promote drug safety and tolerability. So there's a few of the research of historical research on how combination of drugs have been studied for different disorders. So what I'm going to focus on now is in ketamine-assisted psychotherapy. And what is very interesting about ketamine is a substance that has been around for a very long time. It's been proven to be very safe because it was the savior of the Vietnam War on the battlefield. And very, very soon, it was seen that it had peculiar activity on the brain and peculiar effects on the people. So in Iran, they started using it as an abreactive agent. Okay, so it had been used before, barbiturates were used before to help people, come out. But basically what they wanted to do is to give people a very bad experience, kind of a bad trip. So they will just kind of get out and be able to deal with emotions that were coming. So the emotions will come out and they will be able to work with them in the context of psychotherapy. So ketamine has always, in the terms of psychiatry until 2000, been used as an adjunct to psychotherapy. Then in Argentina as well, they will use it for depression. Kuprisky, who is an incredible, very kind man who used it in Russia until it was banned, but who wished he could still use it. He is an addiction psychiatrist. And he started using it in aversive conditioning for alcohol dependence. He thought, if I give people this substance that is going to give them a very, and a very bad reaction, they will stop using alcohol. But what happened and what he observed is that people were getting these dissociations, mystical experiences, they were giving them a very high dose. Mystical experiences, things that are starting to have meaning. And these experiences seem to be as effective as the negative experiences. So what he did is he changed into these experiences and tried to work with them in what he created, ketamine-assisted psychotherapy, and used psychodynamic models, but also used what it is about, well, trying to normalize these experiences and put them in the context of a day-to-day life and what they meant. So work with meaning. And then in 2000, a very famous RCT came out with a biomedical paradigm, and then they try to attribute the effects of ketamine only to the pharmaceutical effect, which is the thing that we can actually prove. The rest we cannot prove because research has its limitations. So, but interestingly, this lasted for 6 years, and from 2006 onwards, we have the rebirth of therapy as ketamine-assisted psychotherapy. And this is a boom in the United States. It's used in many, many different ways. But at this point, as you will know, the psychedelic boom had been in the 50s. They did a lot of study on how to work with psychedelics. So the new wave was basing their way of working with ketamine on the psychedelic method, which is a lot of preparation, a lot of integration of the experience and care for the setting. So what are the current models of ketamine use in therapy? In the UK, the model that is being used is the one that Rupert has spoken about, which is mostly based on the biomedical model, because it's the evidence-based is what we can work with, and it is there. But interestingly, all models have inherited the idea of using music and eye shades in the time that they are using the ketamine. So people are invited to bring their own music, to have their headphones, and go inside to let them go inside. So it's not something that they are encouraged to kind of open their eyes and look around and have the changes. So they will be encouraged to be more introspective. There is preparation. So preparation about what is going to happen, what are the goals. Preparation can range for just telling them what the medication is going to do or what are the side effects, but also can be about what do you expect from the medication, what are the goals, what are the changes that you want to see after it, what are you going to work on. And then there is the integration, and the integration is about, using that space where the neuroplasticity has been open to start on new behavioral changes or, work on affective conditions that they've been working with, or with past traumas or things that may come up. It's a time to use it. So that's kind of the way it works. Some of the biochemical models will not have any of this, but patients might look for therapy themselves. So it's important to keep that. What I wanted to highlight here, and we were talking about the language that we use. In the biomedical model, the dissociation, the hallucinations, the changes in affective conditions are called side effects, and there's undesirable side effects, epiphenomenon, that have nothing to do with what is happening or have no meaning. So, yeah, it sounds interesting, and it might be a waste of an opportunity. It might not be relevant in terms of biochemistry, but the fact is that people who tell you about their experiences, these experiences are incredibly meaningful, and they may affect change, they may affect behavior, they may affect the view of the world and society, which in turn helps with how they can live afterwards. So make these experiences meaningful. We have plasticity-oriented therapies, which is based just on the neuroplasticity, which will use the window of neuroplasticity, which is just after or a few hours, within the 72 hours after the therapy. So the blue will be the ketamine infusion, And the therapeutic modalities that will be used here is behavioral modalities, harm reduction. So yes, making sure that the person doesn't, get disorientated, and acceptance and commitment therapy. And then we have experience-orientated therapy, which is ketamine-assisted psychotherapy. And we have psycholytic therapy. So in the States, is being used historically, lower doses that kind of opens up and allows for the interpersonal relationship with the therapist to be more open, and for the emotions to be less heightened and the associations, and it facilitates the therapy. So the person will take a lower dose of ketamine, and then will have the therapist talking throughout this time. Okay, and it's work for psychoanalysis, trauma and attachment informed psychotherapy, psychodynamic, and acceptance and commitment therapy. And then we have the psychedelic therapy, which is, as we said, a big therapy, bigger ketamine dose, where there is preparation before and preparation after. When I say big ketamine doses, probably the doses is a little bit higher than the dose that is being used in the ketamine clinics, and which makes that during the session, there is no way of communication because the person is a little bit too dissociated. But then there will be a thorough preparation, goal setting, and an integration of the experience. And this is where the new paradigm, to understand, how do we understand these dissociative experiences? What are the meaning? How do we work with that? Is a new, well, it's not new because it's been there from the 50s, but it's now we are starting to try to make sense of this paradigm. So the use of transpersonal psychology, existential psychology, humanistic psychology, and again, acceptance and commitment therapy, because at the end of the day, it's about accepting what happens and learning from it. So I don't know how much time. Yeah. It's just a quick one about the healing potential of psychedelic experience. So again, and I'm talking here about the psychedelic experience because it's very intense and it provides a lot of, neuroplasticity at once. But there is a lot of studies about, and a lot of reports about how this can be really therapeutic for people having mystical experiences, which has also been described by meditators or by people who had near-death experiences. These are experiences that are difficult to qualify. Sometimes you call them detachment or the personalization. But when you talk to the person, even if for the psychiatrist, when they tell you that is what will fill the criteria, they have a meaning, they are remembered, and they make change. So it's just to start to open our minds and think about different ways of understanding altered states. And when we say this, it might also include sometimes what is the content of psychotic experiences and where do they come from and why you have this one and not the other one. It's about more holistic, humanistic approach, which is having a different perspective on what we are looking at. So meaning is very important. So I guess what I wanted to look at here is how, as psychiatrists, we work with research, and research tells us bits and pieces from different things, and it's really helpful because we need it, because otherwise, anything could do, and that's not what we want. But it's important as well, and I think that's what we all do, which is we work with the whole elephant. We work with the beliefs, we work with the legs, the tasks, we work with everything together. So even if we, try to understand the whole by its parts, it's important sometimes to go back and put the parts together and see that's where meaning has a bit more of a role here, because then it's like, you're not talking about why do you have a leg, but the question is, what are you for? What is this about? And this is what seems to be the psychedelic experiences put people in touch with more readily. So yeah, food for thought. I think I've talked about the neuroplasticity, the pros and cons, and, is this the new hype, or is it a step forward? Can we build on it? How do we integrate this? Supportive environment and psychotherapeutic input reinforces the outcome of any of the neuromodulation systems. And it looks like I forgot to put the slide, but If you look at ECT and psychotherapy, there's research, but there is research from 57 to 2006, and then there's no more research. But they were using psychotherapy for it. There is obviously no evidence because every single research paper is using a different methodology with different, frequencies and things like that. But there was research on that. On TMS, there is research with pain. So TMS is being used for restorative neurology. So in neurological cases, they are using behavioral reactivation, they are using acceptance and commitment therapy, and they are using it as well when there is depression, adjust to it. And now what they are using mostly is CBT as well. So it's ACT and CBT are being used with TMS, but I could find 3 papers, okay, when you put the search. Ketamine, I could find 17 papers that were talking about psychotherapy. Again, there are papers that go because it's naturalistic studies from the clinics in the United States, which you cannot, there's no controls, but there is other studies, as Rupert has shown, that hint towards improvement, but there is no hardcore evidence. Nevertheless, we all try to do this. We try to see how we can get the benefits for our patients. We try to see how we can work on traumas, and trauma-informed therapy is now everywhere because it's important. It's important that we consider the whole picture. So what I find is very interesting is we started doing psychotherapy and we started adding the substances as a companion to it. Then research focused on the methods, and we focus on the method, and then we are realizing that it would make sense to work synergically. So yeah, that will be what I will like to say. And also I wanted to say a thought for our colleagues that are in war zones, because I think if we're thinking about systems and where we are, we're living very difficult times nowadays, and that will affect our patients and ourselves. Thank you very much.
Yes. Yeah, thank you. It's such a great afternoon, Geoff. Thanks for organising it. It's really, really useful. I had a couple of questions for Rupert. I was looking in the BNF and I couldn't find the ketamine liquid, so maybe that's special order. And I was going to ask, when you say the racemic ketamine IV, that's just the stuff they use for general anesthesia. And my third question is, I see you're giving oral ketamine. But why didn't we just give oral ketamine in the first place?
Okay, so first question, yes, you're right. Oral ketamine is made up as a special by a compounding pharmacist, and they basically take the IV stuff and put it in with something that makes it taste nice. Yes, you're right. The racemic stuff is the stuff that you use for anesthetics, I'm an old age psychiatrist. What was the third question?
Why do we bother with IVs? Can't we just use oral?
So as I mentioned, I mean, this is a big thing. There are lots of companies, well, there are 4 companies that are trying to formulate oral ketamine for use, and their trials will be predicated on the idea that you can take their medicines without developing dissociation, and they will be antidepressant. And I should be very surprised if at least some of those trials aren't positive, because although we have there's a narrative that you have to have the dissociative experience in order to benefit. Actually, I don't think that's true. I think some people can benefit without having a dissociative experience. And I think it is of itself antidepressant. We talked about how that might be. So the problem with oral, and I talked a little bit about some of the problems with oral. If people are in pain and you've got a pile of stuff here that's going to stop you being in pain, you will take it, and that's the problem. So unless we've got really good monitoring, where people know exactly what people are taking, and they have they're only supplied with small amounts, and it's done in a sort of secondary care setting, I think without that, we're in trouble. Because people will take more than they are prescribed if they're relapsing. And the short and long of it is, I mean, here's another analogy. If you think of depression as a bit like a tube that's filling up with sand, and you know, you can't get any flow through it. The IV ketamine will blast it through, and the oral ketamine just sort of gradually helps you keep clear a little bit, but it's not as good. It doesn't work as well as the IV ketamine, and that's why the dose that Mind Bloom has been giving to people, which is a psychedelic oral dose, is much higher than the dose that we've been using to try and maintain the effect between infusions.
Those trials the trials that you reported were the first line treatment, were they the ones you were talking about at the end, or were they treatment resistant?
Which one is?
Say comparing ketamine to ECT.
No, those are all to people with TRD.
With treatment resistant.
Well, so people who were up for having the ECT, they were needing ECT, so they all had TRD.
So is there much evidence for first line treatment with ketamine?
Yeah, I mean, you know, it'll work better as a first line treatment, of course. You know, I mean, you know, it's take easy patients, so easy to bring up.
I love the way all the research, it always talks about treatment-resistant depression, but when you read through the notes, it says less severe treatment-resistant depression.
Yeah.
It always does better than really severe treatment-resistant depression.
That's right.
You had a question?
Yeah, I do. I mean, I thought Sylvia really lit up the afternoon at the end. I mean, if I may share a metaphor temporarily, then end with a question. I feel like the first three talks were like people looking for the keys in the light of a lamppost. And then suddenly Sylvia comes along, switches on a floodlight that illuminates the whole thing. And we see the much, much bigger picture. I'll ask a question. Why don't this balance between the big picture and the micro detail be obligatory in psychiatry for every single lecture we give? The biopsycho-socio-politico-spiritual model with this brilliant stuff. But realise it's just on the bloody lamppost, for God's sake. The whole picture, including World War III, is out there. What we've got to do in psychiatry to make sure that we always think of this big picture, just like Sylvia did. She pulled the switch at the end. That should be on at the beginning of the talk and in every talk. What does psychiatry have to do to achieve that?
Understand that social dominance lies at the root of it.
Peter Kramer, listening to Prozac.
I'm not the first person.
Kramer, listening to Prozac, 1989, I read it. Social hierarchy of dominance in primates with fluoxetine.
Right.
And then it stopped working.
What does the fluoxetine do?
It increases you give the beta baboon fluoxetine at a high dose, it becomes an alpha male. No, but seriously, I mean, that's the biggest question. Surely that's the unspoken question.
Question at the back there.
Maybe a bit of an odd question. So dissociative phenomena occur both within kind of using ketamine, but also as a response to stress and trauma. So what I'm trying to work out is why one would be beneficial than the other. And I suppose that's asking high.
So dissociation is a defense against the anxiety of the trauma, isn't it? So if you're in a situation where your forced loss is so severe that this is a mechanism that the brain has developed to try and manage that. You know, I can't answer your question as to why dissociation might not be necessary for the benefit of ketamine to work, but you can see that the things, I agree with you, you know, the things have something in common. So I haven't answered the question because I don't know the answer.
I know that if we think about the default mode network and you think about anxiety, it's all very referential. You hate to use the term sort of self-important or self-referential, but one thing we know about anxiety is that when we're not doing an externally facing activity, we start internalizing and we think about ourselves. People who are anxious are always thinking about themselves, whether that's hypochondriasis or social anxiety. It's all about me. It's how I fit in. And what a lot of the studies have shown is that when people take psychedelics or ketamine or even SSRIs, it reduces the self-reference. It takes away the sting of the death in the family. It takes away this, oh God, what does this mean to me? And it allows you to think about a problem from slightly away. And the dissociation allows you to do that. You're not quite in your own body at the time. And some people can. That's why people say it's almost like talking to myself.
If I can add to that, I think if you think of it as the dissociation might be about flattening the difference between yourself and the whatever the dominant thing that's bothering you. Okay, then that's a form of dissociation, that sort of flattening. And if you think of the brain as being fundamentally a comparison organism, that's what it does, is it compares things. Then if it can reduce the distance between self and feared, and that might be, there are a number of ways that you can do that, then that might be the mechanism through which it works.
But, and as well, I guess there is the different qualities of dissociation. What we call dissociation might not be exactly the same. So what happens in a psychedelic state, the dissociation, there is that the quality of it might be different. So the idea that you are flying away might be different in the quality of it, but also maybe in the meaning. So again, the context where this is happening is very different than what it is. So when you are taking a psychedelic and you have a dissociation that creates anxiety, you can revert to the way, well, I took a psychedelic. That's why I'm feeling like this. When you are anxious because you are you are going to fail your exams, or because the war is coming, how do you get out of that? So the self-agency of that state is very different as well. So, you can have to break it in different places, but the context again is very important. And the mindset again is also very important.
I think dissociation is about perspective taking, isn't it? You can take a perspective. I dissociate myself from this. It's not right up here, it's back here. I can take a perspective. And interestingly, what you talk about dissociation, I think as doctors, we've all been in emergencies, and we probably all have that memory of going, oh my God, I'm the only person, I'm the first person on the crash team. And it's horrible for a minute. And then all of a sudden it's got to be done. And that fear tends to go. Sometimes you're almost watching yourself. That's dissociation. That's distancing yourself from the anxiety in order to do the job. Afterwards, you're shaking like a leaf. But and you wouldn't ever wish that on your worst enemy. But during the thing, it's there, it's happening, you've got to deal with it. And I think that's where dissociation has come as an evolutionary thing. When you're running away from a lion, you don't want to be thinking how you feel about it. You just want to run very fast. Anyway, next question.
Geoff, we've already had.
Hi, thank you. Rupert, I think you mentioned that the rates of ECT use in the UK are quite a bit lower than Scandinavian countries. I think there's even quite a bit of variation within England as well. I guess the question's for Geoff and Daniel. I got the sense working in ECT at the Royal London that the rate of ECT use was much lower than you would maybe expect, given the size of the population we have. And I wondered if you have any thoughts on the reasons.
You were talking about the COVID.
Yeah, it's gone down a lot since COVID, but I think so the reason for the variation must lie in the prescribers. It's in the brain of the prescribers. It's how much have they got to you? And so I think I think it's a good idea to have an afternoon like this that tries to put positive, to understand that ECT is underused, and it's about where we set our thresholds and when we give up and when we're happy just to block them away rather than grasp it. I think there's another simple thing, which is that the best has driven out the good. So ECTAS has made things particularly complicated. There's more complexity. I don't buy that. I think that we shouldn't allow that. We shouldn't not refer because there's a load of work that goes with referring people to ECT. We should bite the bullet and get on with it.
I just made on that note, we have radically redesigned all of our referral forms for ECT in East London, and that should be much easier for you instead of just. Question.
Yeah, thanks. Great afternoon. It brings psychiatry to life again. And just this kind of experiential domain, really, in terms of the efficacy of the ketamine treatment. I wonder if you said that it doesn't really require dissociation, but maybe it requires something on an experiential level of subjectivity, where this kind of radical shift in the experiential stance is what matters really as a factor really to determine as to whether it works or not. So I wonder if any of these studies have actually tapped into that, not just looking at something on the basis of a dissociation scale or whatever.
Well, yeah, I mean, if you just to start from what you can measure, which is on the dissociation scale. So the Janssen data suggests that people can be responders without dissociating. Our experience is that people who have previously dissociated and then don't dissociate are, and I don't know whether this is which way round this comes, but they very often get very anxious that they're not going to have a benefit that's going to last them through to their next scheduled treatment in 4 weeks or whatever it is. So, and that's very often the case. They have a wretched 4 weeks because they've not benefited. So there's something about that experience. You're right. I don't know whether it's to do with the expectation. It may be that you know, I personally, I think it's likely to be to do with this flattening. You know, I think that it does something that allows you to, it's obviously pain relieving, as you said. You know, if you've heard expressions about thinking about yourself and it hurts. You know, and so there's and ketamine does have some opiate activity, so it probably is a pain reliever, but I think it could be a sub dissociative experience may be helpful, yes, but I don't know.
I don't think you get it out of a scale. You would have to do some qualitative research to just really get into that level of subjectivity on a patient-to-patient basis.
Like one of the things that is very interesting in ketamine, and one of the reasons why I got interested in is because one of the patients that I saw would say, you know, I finally understood years of therapy. So it's not that cognitively she didn't have that, but there was an experiential, you know, she could feel what had happened to her and understood it from a more subjective place than what it is, you know, doing it in the therapy room, which is the quality difference between ECT, TMS, and ketamine, is that you have that.
And if I can just add to that, there are some patients who will talk with that language, and there are others who are just pure mind depression. And you know, as psychiatrists, that's our challenge, is how we manage those two populations, how we try to bring one population into another, how we try to educate them, how we use language that can speak to people but carry the same message.
It's just a question about access. It's more practical questions. The first one is, I'm not too sure what the answer to this is, but do you think the UK is lagging behind bringing these treatments to patients compared to like America and other European countries? I'm not too sure. It seems like states in America are much more ahead at delivering all of the novel treatments that were discussed today to patients, but I might be wrong. And the second question was about access within the UK. I'm not aware of any private medical insurance that are funding these treatments for patients. So patients are just, I might be wrong about TMS though, and patients are just paying for them like right out of their pocket, which is, again, seems different to other countries around the UK. But again, I might be wrong. Now they're private
so there are some insurance policies that people will be able to get private medical cover for TMS. I think I don't know of any that would cover you for ketamine or esketamine.
Just because you mentioned that the majority of your clinic are paying privately.
Majority, yeah, they're all paying out of pocket. We used to have ICB referrals, but frankly, it's just such a nightmare trying to get the money out of the ICBs, and then the basis on which they will fund it just don't suit this this sort of thing, so we've decided not to go down it.
Yeah, but when you look at America, and I think there's a few countries in Europe too, but again, I don't know a lot about this. It seems like people don't have to pay out of pocket to access the treatments as much, or they don't have to pay as much.
So in America, S-ketamine has been accepted by many more insurance companies now, and that's why Janssen earned $1 billion out of it last year.
Yeah.
So you're absolutely right, but most, I think the majority, in terms of numbers, probably the majority of people getting ketamine are paying out of pocket.
Yeah, and just to the whole panel, do you think the UK is lagging behind other developed countries in bringing these treatments to patients or not?
Spain has it in the national security as ketamine, so it's part of the treatment-resistant depression.
Yes, I do, but I think certainly in the case of TMS, we are in a really exciting time where it's booming. The fact that we've got a service, and we're one of the few in London that have, but they're popping up all over the place. And I genuinely, in the States, you can't go to any sort of small town really without having a TMS machine. Here we have increasing number, but I genuinely think that within 10 years TMS will be everywhere as an adjunctive treatment, to treat for depression. And I very much hope that ketamine will be following very soon afterwards.
I think it's going to be a real challenge to see how interventional psychiatry more broadly is meshed in with CMHTs, this current structure that we have. Because what I find is that patients come and they get this treatment from us and they suddenly feel much better. Why the hell would I go back to the CMHT that has been phoning me up every evening asking me if I'm going to kill myself? It's not been a great experience for me. So then they don't want to go back to the CMHT, and the CMHT certainly wants them off their books. And you can understand why. So then for us, we're left holding the baby. And it's a risk. And we've taken on the most risky population. So,
not really a question, just 2 points. I'm know that MDMA assisted therapy, which is up and running in Australia, has not been part of today. It's something that would have been interesting to see comparisons on how they're managing that and how it's working now in Australia. And secondly, with regards to the lab, the noetic experience that was mentioned about having dissociation or kind of flattening the field, so to speak, and that dissociation and kind of attaching ourselves to meaning without the trauma that's attached to it and can have a great toward healing. I think that's very important. There's many studies like that. I was fortunate enough to be in a team in Imperial College, and I was involved in extended use of DMT, for example, and so there are qualitative work done on it. So it is out there. So Imperial College has a lot of this, but I really do say thank you very much.
Just to comment on the MDMA thing, I didn't quite get the rest of it, but the MDMA, I think it's going to be rather niche. I think Simon's going to be rather niche. I think that, what I'm really interested in is how you get this stuff into practice and in a population and how you scale it. And I think, so, obviously if MDMA works, we get that great, I'm absolutely fantastic. But how are we going to make that work in practice? You're very long way from that. In this country, given the structures that we have.
Final questions?
We got one more question from Ben there.
People are here at 5:15. This is
unprecedented.
Hang on a second. This might form you in. So I've been thinking about what you've all said, and also thinking about what Professor Rorick said, and I'm wondering if the answer to whether the dissociative experience is beneficial or not lies within the kind of Kleinian position in which the experience is had. Has there been any research from that kind of position as to object states when people are taking ketamine?
I just do ECT. I don't know.
I don't know.
Thanks, Dan.
Yeah, welcome.
But another language for that is to think about the internalized people, the people that are internalized, so that they are in fact objects or in another parts, whatever. So and of course, as Sylvia said, that the idea that you might be able to make new meaning through the dissociative experience is that's enticing. It's certainly possible for some people. But again, I failed to answer your question.
Right, I think we're going to wrap it up there. Thank you all so much for coming.